It's Chris Snowdon here again from the Institute of Economic Affairs, and you're watching the Swift Half with Snowdon, another episode of the fortnightly half-hour chat show. Half hour, hence Swift Half. We invented and patented the rights to half-hour television programs. We think they're the perfect length, and we're amazed no one's thought of it before. This week, ladies and gentlemen, I'm delighted to welcome onto the show Dr. Margaret McCartney. She is not she hasn't got a PhD. She's one of those medical doctors, but it does mean that she is licensed to practice medicine. And she's with us right now. Margaret, hello.
Hello, Christopher.
Hi. Now, Margaret, you hauled me up on a tweet last week, which I sent out, and this wasn't a fully fledged think tank idea. It was just something off the top of my head. It did go down quite well, I have to say, with a lot of people on Twitter. I said general practice should be replaced by walk-in centres. GPs were a good idea once upon a time, but most of them work part-time. They don't do home visits and they won't work weekends. They're only middlemen anyway. Get rid of them. What's wrong with that?
Well, my reply to you, I think, was just like Christopher, because it's really interesting about discussing ideas and where it's best to be done, because Twitter can be quite useful for quite a lot of stuff. But, I just wonder how many people actually get better informed by stuff on Twitter, or whether sometimes it's better to take things into a different place and try and talk about them, which is what I hope to try and do here. So I have massive conflict of interest. Of course, I'm a GP, so that's my biggest conflict of interest. Although I did say years ago that if general practice was ever proven to be harmful, I would go and do something else quite happily. So I'm still up for that challenge, still hoping for a second career. So can I tell you about my story? Is that okay?
Please do.
So when I was a medical student, I remember going with a GP for an attachment for a few weeks and going out with him, and he would do a morning clinic, and then he would go home for lunch, feed the dog, see his wife, and then he would do some home visits on the way, and then he would do an afternoon surgery that would go into early evening, and then he would go home, do some out of hours. There would be a driver to take you around and do some out of hours, seeing some patients that really couldn't travel in to be seen in a centre or in the practice. And it was very sustainable. It felt very doable. It was a nice job. It was attractive. You knew the patients knew you. There was no real complaints. Everything seemed to be kind of shuffling along reasonably well. And then when I came to do general practice, this is 23 years ago as a trainee, it was a bit different. So there was quite intense morning and afternoon sessions. House calls would be kind of at lunchtime, late morning. But there would always be time for coffee. We'd always manage to sit down and discuss cases, who was doing what, does the receptionist need to be replaced? Do we need to replace the roof tiles around the back? All the stuff that goes along with a small business. And it was a kind of corner shop model. It was a corner shop and you had your regular customers, you knew them, they knew you. It worked fairly well. And then things started to change. It seemed to ramp up. It became just increasing demand on appointments and an increasing demand out of hours as well. So out of hours used to be manageable. It used to be that you could deal. I remember being on call on Saturdays, and I would be the only on-call doctor for a practice of, I think, something like 15,000 patients. I was on my own. I remember being very heavily pregnant and on my own, thinking, if I get murdered, no one will know where I've been or where I'm going. So it was very, you were just on your own. You just dealt with it, but you had quite a lot of autonomy about how you did it. And then out of hours really started to change. Things really ramped up. More than was safe, more than you could deal with. So it became very, very slick. Practices would share their on-call rotas with other practices. You would be expected to be there in the centre all the time, working hard, rather than being on call from home and having interruptions from time to time. So it really changed, and there was a lot of work from hospitals was moved out into the practices because they realised that we could do a lot of things, but the funding didn't always follow. And then I think there became just this kind of gradual decline, stress, dissatisfaction in lots of areas that has just accelerated. So what you've got now is GPs who are, I think many are very distressed because they can't do the job that they want to do and that they're trained to do. You get patients who are distressed because they want to go and see their doctor and they can't get to do that. And you get the kind of walk-in centres, which are the quick fixes, which work brilliantly if you're someone that is not seriously ill, doesn't have a long-term condition, doesn't really need to see a doctor. You can see a pharmacist, you can see a nurse, you can see a paramedic, not things that are going to be causing you undue long-term issues. So it can work really well for that. If you've got a chronic condition, if you've got complicated medical problems that are interwoven with each other, if you've got if you've got kind of lots of the chronic multimorbidities that we get, and we know that they affect people who are worse off earlier and they live less long with lower quality health lives, that becomes increasingly difficult to sustain. And you can't do it in a 10-minute, 15-minute GP appointment well either. You need all the resources with you. So it just becomes more and more and more impossible. So that's where we're basically at.
But thank you for that. But the objection, I guess, to the walk-in centres, clinics, whatever you call them, is that, you know, you're going to see somebody different every time. You're going to have to explain your whole medical history and so on. But I find, and a lot of people find, that you have to do that anyway when you go to the GP, because the idea of having a family doctor who you see is dead and gone. I think I'm right in saying most GPs now work part-time. They seem to move around all the time. You get them leaving, coming back as locums on twice as much money.
Yeah, let me tell you about that. So now you're absolutely right. So continuity of care, there's lots of evidence that says it's associated with cheaper and better quality care. So that's like really important. GPs like it, patients like it. So it's one of those things that keeps GPs in practice. They feel less stressed, I think, in general, when they have patients that they know, because they're not coming to try to make 100 decisions at a time. They're making sort of 2 or 3 quality decisions with someone that you know. So you're absolutely right. And that has been declining, and there's good evidence to say it's been declining and declining. Well, why is that? Well, when you talk about part-time, so I'm meant to be half-time, 2.5 days a week. So that takes me about 32, 33 hours plus all my paperwork at home. Like the days that I've been in general practice, my head is, full. I'm at my full decision-making capacity. I'm making decisions quickly all day, with little coffee in my system sometimes. It is really, really difficult to sustain. And so a lot of GPs are coming in and they're thinking, okay, I would quite like to do some general practice, but actually that is really stressful and the pay is crap. And if I go and work for a private provider who are offering me sessions from home with a gym and with free indemnity and with free GMC fees paid, all your professional expenses done, and it's less stressful, and it's generally nicer because I have more time with patients. I'm not put under undue pressure to do all the house calls and all the prescription requests and phone back social work and organise a letter for the housing department for this person that needs a house and won't be given it unless you get a letter from your GP. All that stuff will go if you're working in select private providers, and you will be treated better. So if you're having a market system that says you go where where you want according to what your priorities are, that's where you'll end up going. And now it's like dentistry, and you can see a private GP now for an opinion for fees that are much lower than they were in the past. So then what happens is you've got fissures, you've got splits. Then as a GP in the NHS, someone will come to you and say, I've had 3 opinions from various providers and I need this, this and this and this. It's my shopping list. But actually I wouldn't do any of those things because it's not recommended out with guidelines or not evidence-based. So you've got all that to wind back on, and you're trying to offer a good service where you are, you feel as though you're doing your best for the patient. It's a nightmare. It's a nightmare. And as for the weekends, I used to do loads of weekends. I did them during COVID. I did lots of stuff. It is very stressful. It is really stressful. I would very easily take a pay cut for less stress. And that's what people have done. They have decided that they're at their max. And I completely understand that. I don't blame them.
Can you talk us through the business model, if you like, of a GP practice? Because a lot of people don't understand that GPs are not part of the NHS. It's never been nationalised. These are private businesses.
Yeah, well, we kind of are and we aren't, and that's right. That's the tension. That's the tension. So I'm a GP partner, so I'm a contract with the NHS, and it's a very strict contract. So you can't treat your own patients privately, for example. You've got to do exactly what the health board want you to do. So I suppose we are indeed. Our pensions are all NHS. Our staff are all paid on NHS scales. We're interwoven, I suppose, with the NHS. If you've got a private GP practice, they don't have to do any of the stuff, obviously, that's in the NHS contract, which is quite strict and will tell you what you can and can't do. And of course, there's limits to what we can do and what we can't do in terms of treatments that we offer and stuff. It's all kind of NHS based. So that means that we have both the benefit of being an independent contractor and we have the problem of being an independent contractor. So we have to run it like with our staff, with the building. If the building needs painted internally, we come in a shift rota because obviously you can't have patient records left around unattended. So we're in the weekend while the painter's in, so there's all that kind of stuff that's attached to it. And then you've got this model. Now it's quite rare in Scotland, but it's far more common in England, where you have, say, 3 or 4 profit sharing partners who employ lots of people. They employ salaried doctors, they employ nurses, they employ physiotherapists, and they will do the vast majority of patient care. They're not partners. So when our partner retired a few years ago, we were very clear that we wanted another partner to come in. We didn't want to have a salaried doctor because we wanted to be equal. We wanted equal decision making. Also, we wanted equal responsibility. You share the stresses of being a private company effectively. And that has meant that, there has been times when, we've had to, less money and more money, shall we say, if I can put that delicately. So you've got all the stuff that goes along with that. If you're in a big, massive conglomeration, you might want to be a salaried doctor and think you can have a contract where you're working your clear hours, you're negotiating, you're saying, I'll say 12 patients in the morning, 12 patients in the afternoon. I won't do any house calls. I want school holidays off. You could try and negotiate that. I don't have that right. We've got to provide, if someone's off sick, then I'm in covering, whether or not it's my day to be in if we can't get locums or whatever. So I'm really opposed to these big, massive models of a few GPs earning a huge amount of money compared with everybody else, because I think it creates instability. And I also think that you may as well run it by, a massive private company like, Virgin or Accenture or whatever. Why, what's special about GPs running that? Because it really does become a management issue as opposed to a clinical issue. Whereas in a small corner shop, you're at the edge of what you're doing. Everything that you're doing is about the clinical impact of it. It's much less, it's closer to the ground, as it were. Whereas in these big, massive companies, I don't think that there's a strong argument for that being owned by, as I say, a small amount of very high earning doctors. That's not the model that I would aspire to because of the conflicts.
So you're a partner, so you're essentially one of the bosses. This is a cooperative almost, right? Yeah. So why have you got such bad working conditions? I mean, why has it gone down the last trip?
Exactly. Why has it? And I kind of think maybe I should have been more angry for longer about this, because you're right, this contract is negotiated every year. In fact, I resigned from the BMA some years ago because of numerous issues, but this would be one of them. And I think Scottish Government has made more efforts than the English Government to try and come up with a reasonable working solution. But the bottom line is, as a partner, and I think there's an element of Stockholm syndrome in there, because you've always worked for the NHS. I know my patients. I love my job, actually. But the problem is the buck does stop with me. So if there's a million things still to do, I'm the person that it stops with. So I think in general, the NHS has got a very good deal from GPs for a very long time, because we have always worked more than our hours. We've always sucked it up because, there was an idea that you were doing I say a good job. The vocational element, you feel as though your heart's in it, you love it, you feel as though you're doing something for your patients, your personal relationships with people. It's very rewarding. So you do sort of suck it all up. And I also wonder whether part of this is to do with the feminisation of the profession as well. I do wonder whether women have been less, too grateful, I suppose, for being given a job and getting into medical school and passing all your exams and being passed in the head to do well, and maybe not forceful enough in saying, actually, this is unsustainable, we can't do this. And it's interesting when salaried doctors come in, and also when GP services were the out of hours were kind of, that the contract for out of hours was taken from GPs and put into this idea that anyone could bid for it and it was a private thing. The costs went up massively because people were now charging what it was worth, as opposed to people just doing it because it was your responsibility to do it. So as soon as you started to make it pay per hour or pay per visit and everything, the cost just ratcheted up massively.
I hear a lot of GPs complaining about paperwork, and I can understand why. I mean, are you essentially just complaining about over-regulation? Is that the problem with the NHS? They just give you far too many hoops to jump through and forms to sign?
Well, like when I used to refer a patient, I used to dictate something, and now I have to log on. My password's inevitably wrong. I have to click the right box. I have to go to the right place. Then some non-clinician quite often will vet my referral and then decide that my patient doesn't merit being seen, and then I've got to deal with all of that stuff. So it's just layer upon layer. Did your eyebrows raise? I hope they raised, because it's just unbelievable. A few years ago, I got a fantastic letter from a doctor who's now retired, explaining to me why he hadn't seen my patient, and it was a fantastic sort of 2-page rant saying that my referral hadn't been seen by a doctor, it had been seen by someone unknown to him who had decided to reject it on no good clinical reasons, and now he was trying to basically mop it up. And again, these are these kind of money-saving initiatives initiatives, these referral management centres that were sold, I think, to the NHS as a way of reducing unnecessary work, but actually it's so much more complicated than that. I mean, I used to be able to phone up and speak to a consultant and say, you know, about your patient, but, you know, what should we do? I'm a bit worried. There was that informality, but now so much, and I'm not saying that can never happen, but now so much of stuff is managed through a computer interface that's very, you know, tick this box or don't tick this box, and that depends what pathway you're on. It's dismaying.
Yeah, you'd like more autonomy in your job, basically.
Well, the contract is restricted. I mean, a classic example is the new GP contract in Scotland a couple of years ago. They said that we were going to get more staff, which is great, but we couldn't choose the staff, and the staff were going to be still employed by the health board. Right. So, you know, right away, you've got a kind of tension between what we want and need and what the health board thinks we want and need.
Right. So it's a private business that's so heavily regulated by the state that it might as well be part of the NHS.
It would be much better for many people in many ways, but it'd be far more expensive, because if it became the case that we negotiated our contracts like consultants do and say, okay, and we're only going to see these patients, this many patients at this clinic, and then there's a cut-off, your waiting list would just go up and up and up. That's what happens in hospitals. You know, they have a clinic, and the clinic starts and it stops, and then everyone else goes onto a waiting list. Whereas in general practice, our clinic starts, and then everyone that says that they need to be seen that day will just keep adding on and adding on and adding on.
And how does the money come in, as it were? I understand it that you get paid basically, and it might be different in England, but you essentially get paid based on how many people you have on the books, as opposed to how many people you actually see. Is that right?
Yes, so it's not very much. I mean, I can't remember. It's between like sort of £60 and £70 a month, a year for a patient that's on your books. And I think that they can come in as often as they want to. So you've got lots of patients that hardly come in, and then you've got loads of patients that come in like all the time because they've got loads of stuff that needs to be sorted out. So you get extra money for things like vaccinations, or for this thing called chronic disease management, which is a kind of, you know, if you've got heart disease, you're reviewed once a year, your medications looked at, all that kind of stuff. So there's all these little bits of pieces of money. You know, cervical screening gets a little bit of money. What else? Prescription reviews get a little bit of money. There's lots of little bits of jobs that all get added up. So the practice manager's job, I mean, I think a huge amount of her job is to work out all the things that we've done. And a lot of that is in the computer now, and then make sure we've been paid for it and then chase it up. I'll tell you a great one. This is a fantastic one from a few years ago. We were paid money. So, you know, I mean, it's nuts, but you get paid money for different activities. And one of them was to have a palliative care meeting. And I think it was something like every 3 months. And so we have meetings where we invite the palliative care team, district nurses, health visitors too. And we were having a meeting, and we would routinely have done our palliative care work then anyway, just reviewing patients, making sure we're doing everything we should do for folk. And the health board refused to give us the money because they said we had our meetings every 3 calendar months as opposed to every 12 weeks. And they withheld the money.
Really? Right.
Yeah. So that's how tedious and stupid and pathetic it is.
Yeah. So it's massively overregulated.
It's nuts.
This is a problem, isn't it?
It's nuts.
People need to be given, you know, maybe the odd target here or there, and then left to decide how to go about meeting them, rather than
so the
incredible micromanagement like that.
Yeah. So the target thing is really interesting, because I've never come across any sort of really helpful targets in healthcare. You know, every time there's a target, it's gamed. You know, there's a side effect, there's a consequence from it. It's rubbish. And then when you rely on people's professionalism, that can really help. But there will always be some people that will just, if I can be frank, take the piss. You know, so you will find that there are some people who are just not doing what they should do. Now, sometimes that's because people are distressed. They've got, you know, the resources that they have is not matching the demand on their service. And sometimes those people or those practices need a lot of support. And I think it's good to be transparent and say, this is what we're doing. And, you know, you want to be in the pack, you don't really want to be an outlier. So I think there has been a move towards, you know, publishing more data and stuff. But even then, it's really difficult. You know, you go to meetings and you're told, okay, this is how many referrals you've made to neurology compared with this practice and that practice. I don't know what that means. Is that good? Is it bad? You know, so data doesn't really help you, you know, and it's difficult to know what targets you make from that either, you know, that are helpful.
What are the stupidest ones in terms of like the little bonuses you get? Because every now and again you read in the papers that the government is thinking about paying doctors an extra tenner for every smoker they refer to a smoking clinic, or things like that.
I mean, there's mad things. I mean, I think that contract is still more, I think, at large in England than what there was. But there was a thing about smoking cessation, about obesity recording as well, if you recorded or not. And I thought that was really unethical, to be honest with you, because, you know, when patients come in, I think the research says people have got between 2 and 3 things that they want to discuss with their doctor. And you've only got, you know, 12 minutes or however many minutes it is, 10 to 12. And if your patient's just been bereaved or their mum's just been told they've got cancer, and like you're only paid if you say, and do you want to stop smoking, or, you know, are you overweight?
Yeah. Have you noticed that you're overweight? Would you like to do something about that?
It's pathetic.
Yeah, it's incredible. But that's what you get with a, you know, top-down healthcare system where the government's under constant pressure to deal with this, deal with that. It's a bit like with the schools. You're always said, put this on the curriculum, put this on the curriculum, until it's like, well, when are we going to find time to do any work? Right, we've heard a lot about the problems doctors face. Let's talk a bit about the problems patients face. I was looking at a survey before. This is from, I think, May this year. It said that patient satisfaction with GP services has fallen from 68% in 2019 to 38% now. And that when asked what the priorities for the NHS should be, this is for the whole NHS, the top answer with 48% of people was to make it easier to get a GP appointment. Now, you talk about the unintended consequences of targets. One of my pet peeves with GPs, apart from the fact that it seems now impossible to get any non-urgent appointment whatsoever in my surgery, is what I call the 8 a.m. racket, where you ring up for an appointment, you're quite happy to take an appointment the next few days, and they lie to you, so they haven't got any, but if you ring at 8 o'clock in the morning, we'll maybe squeeze you in. So you ring up at 8 o'clock in the morning, what happens? It's engaged because everybody else is doing the same thing. So eventually, if you're lucky, you will get through some hateful receptionist who will triage you and maybe decide that actually we've got something at 9:30. Can you come in now? Now, my understanding of this was that this at least started off as being a way to game the same day appointments target. And even though that target doesn't even exist anymore, they've stuck with it because it makes life easier for them in some way. Is that right?
Yeah, well, I don't know what your individual practice is doing, but I mean, I think this whole thing started with Blair, you know, this idea that you were going to have, you know, that there was going to be targets and you could always get a same day appointment. And then, of course, what happens is the system is gamed. So you can get a same day appointment, but you can't book for 1, 2, 3 in advance. And then it's a capacity.
It's
and that's
terrible, I think. A terrible way to, you know, in primary care, your first contact, you know, with some health problem it involves you basically being lied to straight away.
So I am, before I try and answer that, because I think you've got an extremely good point, I have to say our receptionists are amazing, and just, you know, they are just incredible. You know, and my receptionists in my practice, they know their patients, they help people to try and get through. They are just fantastic. But I completely get where you're coming from. You phone up, you want an appointment, you want to speak to a doctor, you want to see a doctor, and it's not happening. So the fundamental root cause is underinvestment in general practice. So there are not enough appointments compared with demands. That's the number one thing.
But there are, though. They can always squeeze you in on the day if you ring up 8 o'clock in the morning.
Yeah, well, I don't know what system.
My place.
I don't know what system they're using, but I'm sure you're right. So people are trying to manage this demand in lots of different ways. So, you know, there's like the e-consult thing, you can fill in a wee email form and then they try and put you to the right person. And I think part of the problem is that they're trying to say, okay, you might not need to see a GP, you can see a nurse, you can see a physiotherapist, you can see a pharmacist, you know, trying the capacity in general practice. They're trying to say, I think, it shouldn't depend on just GPs. So we don't have more GPs, but might have other people that could help. And I think the purpose of these kind of, I hesitate to say triage system, but it's almost a sorting system when you phone up the practice, is to try and put the people into the GP that can only see the GP and try and deal with people that can be seen by pharmacists elsewhere. Some sense in that. Not a lot of evidence really that it works terrifically well, to be honest. The evidence in triage systems in general is fairly poor. You know, some practices think they're fantastic and it works. Other practices have seen massive increases in workload when they've tried to put in a kind of triage system or whatever. So I don't think that works. So I don't know, Christopher. I don't know what the right answer is. Certainly, I don't think I have it in my practice. Every day we could, I could do with 3 times as many appointments. There was some point during the pandemic that I just came home and I was just about in tears because I'm a grown woman. I'm meant to be, like mature, but it's just really difficult because if you're not giving the kind of care that you want to give the care to your patients, because why would you not want to do that? You're in this because you want to try and do something useful, and you can't do it. You can't magic up more of yourself. You know, when you want to go home at some point, it's really hard. So I don't know what the answer is. I don't know. I have no good answers. I have no good ideas.
I've got an idea for you. I'll give you in a second. Just after we talk about Rishi Sunak's idea of fining people £10 if they don't turn up to GP appointments.
Yeah.
I gather about 5% of GP appointments, people don't turn up. I have heard from quite a few GPs that they quite like it when people don't turn up because it gives them a chance to catch up.
Yeah.
And get things back on schedule. But you're not a fan of this idea from Rishi, I don't think.
It's just stupid. But I mean, from a purely economic point of view, how much money would it take you to recoup that money? Because then invariably people are, the people that don't turn up. I mean, sometimes it's just a confusion or a muddle. Sometimes people have genuinely forgotten, but often it's because people don't have phone credit. There's been a big study done looking at people that don't turn up to hospital appointments, and these are the people that die younger and have the most diseases. So there are reasons why people don't go to the hospital for their appointments, and it's unlikely to be solved by a fine, effectively. There's no evidence at all it's going to make.
What are the main kind of reasons? That they just are too ill to come in, or they forget, or what?
Quite often, nobody really knows, actually. I think that's the other problem, but I think sometimes people don't. Well, there's lots of reasons. Inability to get there, inability to phone and cancel, inability to actually manage to get there, transport, understanding the letter, understanding where to go to, at what time, to do what, all that kind of stuff. But I don't think people really know why. I have to say, with the phone triage system, there's very few people don't turn up because you phone them, and then if they don't answer, you phone again, you leave a message, and eventually you play ping pong and you do manage to speak. So that does take away a huge amount of it. The hospital clinics that I'm aware of, they often routinely overbook because they expect 2 or 3 people not to turn up. So
yes, by the airlines.
Yeah, so if everyone turns up, it's a bit of a nightmare. Yeah, so I don't think that Richie's. I mean, it's a zombie policy. Every couple of years, somebody comes up with this, and some people think it's great, and it's pointless. It's stupid.
What about what I prefer to do, which is charge everybody 20 quid, regardless of whether they turn up or not. Just as a across the board, you pay 20 quid to see your GP. That would raise £5 or £6 billion. We can pay people more benefits or lower taxes and things if you want to try and make that progressive or what have you, but make that the norm. And not only do you deal with the people who don't turn up, but you put off the malingerers, which, let's face it, the whole triage thing and the receptionist, it's all there to try and put off people who shouldn't be going into the GPs and just want a nice chat or get some free paracetamol anyway. So charge people 20 quid. If it's not worth 20 quid, then you're not very ill.
No, I don't buy that, to be honest with you. So first of all, 20 quid is nothing to Richie Sunak. That's small change, fluff in the bottom of your pocket. But 20 quid to a lot of my patients would be, that's this week's shopping and their bus fares. Do you know what I mean? So £20.
Do it in Sweden.
Well, Sweden.
Do it in a lot of countries. Do it in New Zealand. No problem. You pay your 30 quid, you go and see a GP straight away. It doesn't matter how much money you've got. If you're ill, you'll go see a GP.
Well, Sweden has a very different gradient of inequality compared with the UK. So I don't think so. The other thing is just unintended consequences. So the study that was done about nursery kids, and they said, okay, if you're late coming up to pick up your child, we'll fine you £10. About this. Yeah. And what happened was, instead of people being less late to pick up their kids, they were more late because they thought, it's only £10 to have.
In for a penny, in for a pound.
Yeah. So I
forgot about that.
Drink after work. So I don't really think it would work. And the other thing is that some people need a shed load of healthcare. They need massive amounts of healthcare, and some of that is preventative. The people that you categorise as malingerers, I don't think I would categorise anyone like that. I certainly think there are people who have had very bad hands in life and who find it much harder than other people to get on their feet and to manage. I certainly think there's a lot of loneliness out there, but there are lots of organisations that try and help and try and make sure that GP services are used appropriately. And there are places, and again, we used to have a really strong, a well organised and centrally funded suite of community stuff, community centres, stuff going on there, classes, groups, exercise classes, things that would really keep people going, that were very distinct from healthcare services, in control. The community was in control of it. The community worked out what they needed and organised around that. And what we've had over the last couple of years is what I see as a bit of a disaster, this very professionalised social prescribing model where doctors are the gateway drug, or the doctors are the gateway. They prescribe social interventions for you, and they prescribe gardening or working in an allotment and all this kind of stuff. And I think that's just terrible, because these are community interventions that should be owned and run by the community and should have nothing to do with doctors, and doctors should take their hands off them and let people themselves own and run them. But the problem is that so many of these community resources have been stripped back, so there isn't the same. I mean, in social social care, you know, social workers, you know, who do an amazing job on practically thin air. You know, they used to be able to come in and help people, you know, get back on their feet, support people that were struggling, and they just are unable to do that now, except if there's people that are at really high risk, which of course has an impact in general practice, because these people have needs that are being met unmet elsewhere.
We're out of time, I'm afraid. Margaret, I have a feeling if we kept chatting for long enough, we could find a lot of common ground, but we haven't got time. It's only a half-hour program. Thanks very much for joining me. It's been great chatting. Thank you at home for watching. We'll be back in a couple of weeks. I think I'm on holiday, but I think I can do 1 in 2 weeks anyway. You take care until then. Thank you, particularly IEA donors. If you want to give us money, iea.org.uk/donate or patreon.com/IEA London. See you again next time. Cheers. Goodbye.
Well, if you enjoyed that conversation, why not watch one of these other videos? And while you're here, remember to hit the subscribe button and the notification bell. That way, you'll never miss out on a single IEA broadcast.